Yes, the price is still in the other call, but
It's fine.
if we start, yeah.
Okay. All right. Dr. Price, will you introduce yourself and tell us about what you've been working on?
Yeah. So I am Matt Price. Yes, I am Ray Price's son. I'm currently a research resident at Johns Hopkins. I've done 3 clinical years, and I'm doing a Master's of Public Health this year. Which one are you seeing right now? Are you seeing presenter view or non-presenter view?
The title slide.
Just the title slide, okay. Okay. So yeah, I'm in my first research year of 2 research years that I'll be doing out in the lab, and I've been working on this project that I know you guys have seen probably several times with Sarah Schoenhals and Meg Molly and many others having worked on this project. And the portion that I've been focusing on is the availability and geographic access to hospital-based breast cancer early detection and diagnostic services in Ghana, while Sarah's been focusing more on the treatment side of things. So just for a little bit of background leading into it, breast cancer is now the most common cancer diagnosed globally, irrespective of sex, and accounts for more disability-adjusted life years lost than any other malignancy. In fact, in the next few years, there will be 5.8 million who will die globally from breast cancer, and that's by the year 2025. Many countries are being affected by breast cancer. There's actually a disproportionate number of deaths occurring in low resource settings. One of these countries being disproportionately affected is the country of Ghana, has a population of 32 million people. And in Ghana, breast cancer is the leading malignancy, and this figures here among men and women. If we focus solely on women, it accounts for nearly 32% of all malignancies diagnosed. So with early detection and diagnosis, we know that breast cancer can be survivable. We see this in many high-income countries where 5-year survival approaches 90%. There's several studies in Ghana showing 5-year survival varies between 32 and 38%. There's many factors attributing to this low 5-year survival, but one is stage at diagnosis. In Ghana, stage at diagnosis is generally stage 3 or 4. They present fairly late. And also attributing to this is days to diagnosis, meaning from initial symptom onset to pathologic diagnosis of the disease. It takes nearly 8 months in Ghana to get the diagnosis. In the United States and Canada, it's under 50 days. It's really around 38 days for that diagnosis. It's known that a greater than a 3-month delay is associated with higher stage of breast cancer at diagnosis. For this purpose, the WHO and their Global Breast Cancer Initiative has made one of their central pillars of increasing the percent with evaluation, imaging, tissue sampling, and pathology within 60 days. And that's really what the overall project goal is with this project that Dr. Sutherland and the team has been focusing on, and trying to figure out how we can decrease the days to diagnosis, and in doing so, decreasing the stage at diagnosis, and eventually with the overall goal of increasing the 5-year survival. In a study out of Ghana, it's shown that greater than 80% of patients who had to travel more than 1 hour for care would rarely or irregularly seek care. And another study out of South Africa showed that patients who live greater than 20 kilometers from care are more likely to present with advanced stage breast cancer. So step 1 in this project and really decreasing the days to diagnosis is identifying what current services are available. It's hard to know where you need to go if you don't know where you are. And so that's where this survey came from. This is Dr. Sutherland here that I know many of you have interacted with. He's a medical doctor, full-time researcher at Ensign Global College. He's also the site director for West Africa for the Center for Global University of Utah Center for Global Surgery. And Dr. Sutherland and many of the colleagues at the University of Utah developed a survey that was really a combination of the surgeons overseas and the PIPES surgical assessment tool, but really focusing on breast cancer and the resources required for the NCCN framework for resource stratification. So the National Comprehensive Cancer Network has this resource stratification where hospitals can be stratified based on the services that they have. So a basic level hospital has all essential services needed to provide the basic minimal standard of care. These services being clinical breast exam, excisional or incisional biopsy, ER/PR testing, diagnostic ultrasound, or mammography. You go up in care. This adds additional services that provide major improvements in disease outcome and are not cost prohibitive. This is core needle biopsy or FNA with the addition of all the basic level services. And then the level of care can go up from there with breast MRI, CT scan, and then all basic and core level services, as well as HER2 testing. So in this survey, they assessed for all of these individual services if these were available at hospitals. And it was further assessed if these hospitals had these services mostly available, defined as greater than 80% in the previous year, sometimes available, meaning less than 80% in the previous year, or not available. And so Dr. Sutherland and team trained 8 research assistants in each of the components of the survey, and then administered this survey throughout Ghana. And this was administered to all health facilities with a hospital designation. Prior to the survey being administered, letters were sent in advance from the from the Ghana Health Service, and ethical approval was also given by the non-Ghana Health Service eligible hospitals as well. So from November 2020 to October 2021, the survey was administered. And really, I think it was the buy-in from the Ghana Health Service sending those letters that there was really a significant response rate in that 328 of 346 hospitals responded to this survey. This is just showing where the hospitals were who were surveyed. As we can see, obviously the regions that have a higher proportion of the population in Kumasi, Ashanti region, as well as in Greater Accra that had the majority of hospitals. But really, we see nearly all hospitals participated. It was in Accra where 12 hospitals, so 12% of the hospitals in Accra did not participate, but pretty much all other hospitals with a hospital designation participated in this survey. And here are some of the results. Now, I know this slide has too much to really focus in on, but what I wanted to highlight here is each of the individual services we're now able to map out where it's available greater than 80% of the time, less than 80% of the time in yellow, or the black triangle, the hospitals that do not have this service, or stated in the survey that they did not have the service. So you see in A, there's clinical breast exam, excisional biopsy in B, and G is our mammography services, C is our pathology services. And so we're going to go through a little more zoomed in on several of these, but not all of them. So excisional or incisional biopsy, 91 hospitals have this available greater than 80% of the time. We see in the Western North regions, no hospitals have access to this service. In the North, there are several hospitals that do, but many that do not. We're also able to calculate the proportion of the population who lives within 20 kilometers, which is 56% of this service. Pathology services, we see a similar trend in that the Western North regions, while they do have access to pathology, this service is available less than 80% of the time. There are actually only 9 hospitals that reported in-house pathology, but all the other hospitals, 127 hospitals who had access to pathology, but as an external send out. We also see up in the North, only a single hospital had access to pathology services. Diagnostic breast ultrasound, we see that's really throughout the country, there is availability. 56% of the population lives within 20 kilometers of this service. And so we're able to do this for all the basic level services. And these are those listed here. I'll just note here down at the bottom that diagnostic mammography, we showed that 21 hospitals had access to a mammography machine. But this does not take into account any NGOs or other services that were not included in the survey. This is the core level services. So on the left is core needle biopsy. On the right is fine needle aspiration. I'm just highlighting the core level services that are available. And that's that table here showing the population and the number of hospitals that had these services. And finally, the NCCN enhanced services. Now there's more than 4 services required for enhanced, but I didn't make a map specifically for bone scanning because only a single hospital had access to a bone scanner. But we see here up in A is our skin punch biopsy, B is HER2 testing, C is our breast MRI, of which 8 hospitals had access to, and then our CT scanning. And that's listed here as well. Genetic testing, though it's an enhanced service, this was asked in the survey if the hospitals provided genetic testing. This was not clarified if hospitals had access to genetic testing in the surrounding communities. So now that we have all these individual services, one of the big components of this is we can now be able to see these hospitals in what level of stratification they are in, which hospitals meet full, basic, core, or enhanced level of services, which meaning all of the basic services, all of the core services, and all the enhanced services. And what we see is this. So what I have here in green circles are basic level services greater than 80% available. Squares are meeting all basic and core services greater than 80% of the time. And then yellow is the same, just for available less than 80% of the time, meaning some of the services are available less than 80% of the time. We see here in the central and western north regions, there's no hospitals that have really centralized care. And up in the north of Ghana, we still see a lot of areas that don't have centralized care. And these are the hospitals here listed now, the number of hospitals. So 12 hospitals met full basic NCCN criteria greater than 80% of the time, with 30% of the population living within 20 kilometers of that care. 10 of those 12 hospitals met core level services, and no hospitals met enhanced services. So talking a little bit about that, there were 3 hospitals that nearly met full NCCN enhanced services, one in Kumasi and one in Accra. Apologies, 2 in Accra. The one hospital that has access to a bone scanner didn't have access to excisional or incisional biopsy greater than 80% of the year. And then the 2 other hospitals met all criteria, they just did not have access to a bone scanner nor genetic testing. One thing I failed to mention earlier is this is the NCCN framework for resource stratification solely focused on early detection and diagnostic services. The full NCCN framework includes treatment services as well, but that is being looked at with a different project. So step 1, identify the services. We've been able to map out where these services are, which brings us to step 2 of identifying gaps for targeted expansion. So I'm going to briefly talk us through a patient who is seeking care. Let's say they've found a concerning breast lump and they go to seek a clinical breast exam. This patient can go to this hospital here in the Upper East for a clinical breast exam. But if they have a concerning lesion that needs a diagnostic ultrasound, they have to go to a different hospital to seek care. And once they have their diagnostic ultrasound, if further excisional or incisional biopsy is needed with pathology, they have to go to a further hospital. And really this discontinuity of care makes it really challenging to decrease the days to diagnosis. And that broken up care really increases the time to really get that official pathologic diagnosis. So here what we've mapped is the same thing as before, just with all hospitals who met at least NCCN basic criteria greater than 80% in green, less than 80% in yellow. And we've added 5-kilometer concentric ring buffers with the dark red areas showing areas that are, or highlighting areas that are further from centralized care. Again, we see Western North and Central, and then a lot of areas up in the North. To zoom in a little bit further and add in a population density, which we see here with these dark areas here, this is highlighting areas where there's a significant amount of population. In looking at each of the hospitals in that region, we're then able to look at which hospitals meet most basic level services, but are lacking in several services to meet full basic criteria. And with targeted expansion of select services, essentially we could expand services to those regions to have centralized care. We're able to do this actually throughout the country, and we essentially identified 10 hospitals who were lacking in several of the services that could be potential hospitals to expand services to allow for centralized care. This is one of these here as an example for Hospital 4. Hospital 4 here has clinical breast exam, breast ultrasound, incisional biopsy, and x-ray. They don't have access to pathology or ERPR testing. And so if there were ways that referral pathways could be set up for these services to be sent to an external pathology site and have this pathology read, essentially hospital number 4 could meet full basic level criteria. On the, if services were able to be expanded to these 10 hospitals, this would expand centralized care to another 17% of the population, which is about 5.5 million people. There's obviously other components that are important to days to diagnosis that weren't necessarily looked at in this survey. Some of these being awareness and education. There are current awareness and education campaigns in Ghana, but mainly highlighting that the sooner you recognize symptoms and are aware of symptoms, the sooner you're going to seek care. And that's a big factor in decreasing the days to diagnosis. Affordability. This is either the actual cost of care, the perceived cost of care, and really finding ways to make care affordable for patients. Quick note on screening. We should mention that many high-income countries have achieved great success in improving long-term breast cancer survival with national mammography screening campaigns. However, national mammography screening campaigns are currently not recommended in sub-Saharan Africa. This is largely due to the cost of the national screening programs, but also due to the genetic makeup of breast cancer. And when patients present, generally in sub-Saharan Africa, they're presenting below age 40 with this diagnosis, which is prior to when screening would occur. Many countries are not yet equipped as well for the influx of diagnosed patients who would require treatment. Which brings us to the last point of expansion of services expansion of early detection and diagnostic services should not occur without tandem expansion of treatment. By having expanded resources for diagnosis and having more patients diagnosed, there's nothing more frustrating than having a diagnosis but not being able to seek care. Several limitations of this study is this is strictly hospital-based. It does not include surrounding clinics and NGOs who may have several of these services, though obviously many of the biopsy services are more concentrated at the hospitals. And though the survey was considered accurate at the time of the administration, the data is already 2 years old, and some of these hospitals may have different types of services available. So in summary, hospital-based breast cancer early detection and diagnostic services are available, but fragmented throughout Ghana. Northern Ghana and Western North regions are the most limited in their services, and potential targeted expansion of services could result in an additional 17% of the population having access to centralized care. I want to briefly thank everyone who's put a lot of time and effort into this project. Obviously, the Ghana Health Service and Ensign Global College have been critical in this, as well as Dr. Sutherland and all these others who are listed here who have really provided great support in either collecting the data, analyzing the data, and have put a lot of work in. Questions, comments?
Great job. I have a few questions. Listening to this presentation made me wonder if there have been any studies just looking at what factors contribute most to breast cancer mortality in Ghana. How much of that is related to access, how much of that is related to pathologic grade, because there's a lot of literature saying that the pathology of breast cancer is fundamentally different in sub-Saharan Africa. And the reason I say that is, I wonder if there's any attributable mortality assessment or regression analysis that would be useful to do, to then say, where do you need to intervene the most, whether it's for access or treatment, right? Because you know, we don't necessarily need to know, we don't necessarily know that changing access will necessarily change outcome, because if it's just very high grade, you know, everything negative, then maybe that's not something that's salvageable at all.
Yeah.
And even things like screening, as you mentioned, I mean, the screening age is recommended for high income country settings. We have no idea what the screening age should be for across the sub-Saharan African setting, because it seems like pathologically almost a totally different disease. So that's a question. I'll have a couple of other ones, but why don't you start with that?
Yeah, so that's a great question. I've seen several studies out there discussing several of those points. So one of the type of genetic makeup of what breast cancer is in sub-Saharan Africa, there's several hypotheses that it is genetically completely different. Patients are presenting earlier age, and that's really a big driving factor that's going to prevent being able to do mammography screening campaigns once, let's say, it's affordable and available everywhere, if that's really going to be effective. There's another school of thought out there that's saying, well, in reality, it's not presenting earlier. It's just there's the ones that are picking up, yes, are likely more aggressive, but in reality, there's people aren't living as long as well. And so in reality, once you adjust for the population age and dynamic, they're saying in reality, there may not be a genetic factor. There's not a lot of studies specifically on what the genetic makeup is. I'm more of the thought of, you know, it seems like it's presenting at an earlier age. This does seem like this is genetically different. Apologies if you can hear my daughter screaming upstairs. And then the other component, you bring up a good point, is will bringing services closer, will that really be the greatest effect? And I agree that it'd be great to do a regression analysis on something specific from this data. But right now, this is more the geographic mapping and availability, but I don't have anything specifically targeted to do a regression analysis on.
Yeah, it's not so much for you to necessarily do for this project, but it seems to me that would be another question that perhaps would be worth asking. So for decision makers, for policy makers. Other questions, thoughts, comments before I continue with my laundry list of things that came up?
Yeah,
So
I
I
did.
just had,
I'm sorry.
no, go ahead. Go ahead.
It sounds to me from what you were saying that a rate limiting step is, or a rate limiting service is pathology, both anatomic and diagnostic or clinical pathology. And have you done a sort of a similar survey of what the pathology services might be in Ghana, or even through telediagnostics?
So yes, there's actually telediagnostics. No, we've not specifically looked at that, but what we have looked at, which I didn't share in this, we're actually doing a separate manuscript that's strictly on pathology that I didn't necessarily share all that here. But there is we've been able to see specifically where pathology is taken from and where the pathology is read from, which is an interesting component as well. Let me pull that up here real quick. Right here. Let me share this here. So here, there's this is pathology services. So first, greater than 80% available, the same thing we were looking at before, and less than 80% available. But looking strictly at the hospitals who have pathology services externally available, meaning they send it somewhere else, this is mapping out where they send it, take it from, and where they send it to, meaning all of these hospitals in green send their pathology to a single hospital in Kumasi. All of these hospitals in blue send them to a single hospital down in Accra, with several other hospitals having pathology, but really 60 hospitals send it to this hospital and 31 hospitals send it to this one. And so some of these factors that I'm going to be looking at is distance between the care. Obviously, roads and other factors are going to be limiting steps, but we kind of have a separate analysis we're doing with this, and I have a pathologist from each of those centers, the two major centers there, kind of helping look at the data too and figure out what more we can do with it.
Yeah. So what you're saying is kind of what my impression has been when I've been there, and actually is reflected in many other sub-Saharan African countries, that there are only very few centers that actually do the pathology, even though it might be available by sending specimens for referral. But then that takes time, both for the transport of the material and also for reading because of overload. You know, I mean, if there are a limited number of pathologists at each of those two centers, they can only read it so fast.
Yep.
So that element of where it is doesn't necessarily reflect how fast they can process it all.
And they do
get back a
have,
result.
they did report in the survey, this is hospital reported, meaning the ones that are sending it out reporting how long it takes them to get results back.
Mhm.
And it was, I think 25 of the external referrals say they get it back within 2 weeks. 80 said within a month. And then there was only 8 hospitals that said it took longer than a month. Though talking to several individuals in Ghana, it sounds like some feel like that it may take longer than what the survey itself seems to be indicating.
Thank you.
Other questions, comments?
Anil, why don't you go ahead?
Yes. So one of the questions that I have is that looking at the heat map, it looks like the Upper West area of the country is the one that is more affected, right?
Correct.
The one that has the least access to services. So the thing that I was thinking about is, I don't know, because I've never been there, so I apologize if this is a dumb question, but do we know if there are any collaborations between countries, or if maybe a neighboring country may be helping the Upper West area of Ghana?
I think that's a fantastic question. Even Upper West, Upper East, those both don't have it. So essentially asking, do they have hospitals they can be going to right along here?
Right.
Great question. I don't know. And that is something that can be looked into a little bit more.
Thank you. And the other question that I had is just because this is something that we run into in other projects, and it's data collection. How many people did Dr. Sorry, I just forgot his name, Edward Sutherland, train for the survey administration, and how long did it take to train these people, and how did you involve these people to collect the data and participate in the project?
Yeah, so the training actually was a little hampered by COVID. Obviously, you see the time frame when this ran was 2020 to 2021. Dr. Sutherland actually recruited 8 research assistants, and then it was actually Meg Molly who did most of the training of these research assistants, essentially taking them through each component of the survey, all of the questions, had some extra training on breast cancer. I need to actually ask how many specific trainings. I imagine Dr. Price Sr. would have more comments on that. I got involved a couple years after that was done.
Yeah, that process was really quite interesting because we'd done the eastern region and had some of the people trained there. Then when we did the countrywide, COVID had hit and we had to shut down our countrywide project. We were able to get that up pretty early because we had our in-country office with Dr. Sutherland. And so Meg came up with 7 different modules that she then trained remotely from here in the US over time. The people who had done the eastern region were able to go out and do site practice visits and see how they were done so they could all standardize it. And so it was actually, I think, a pretty cool example of what could be done during COVID and remotely to be able to get that up and running again.
Were they all voluntaries or?
Yeah, we have the connections through the Ensign Global with a lot of people who were graduates of the public health and are students of the public health program there.
I guess you're also asking, Angel, were they paid?
Yes, because that's something that I was wondering now that we were in Cambodia for data collection, like who could be the person that helps us collect the prospective data.
Yeah, the answer to it is they were paid.
Okay.
Okay, yeah. I would say I hope so, since it was a year-long survey with a lot of work to go to all these places, but it sounds like yes.
Okay. Thank you.
All great questions. One thing that struck me when you went through your maps of what facilities provided what kind of services was where the facilities were that didn't respond, and if they clustered anywhere. And you know, is there any place that, yeah, like slide 29. Yeah, so those, okay. Yeah, so I think that's also useful to just see, because if they clustered somewhere that is in the north or in, you know, in some other setting for some reason, then that would also be useful. It is interesting that 12 hospitals in the greater Accra region didn't participate. And it might even be worthwhile to reach out to them and say, here are the findings for the country, and you know, do it with it what you will, but your data is not included in this. And but hopefully this information is useful to the services you provide.
Yeah, I think that'd be helpful. And I've talked a little bit to Edward about the makeup of these hospitals. Sounds like there is one fairly large hospital in Accra that did not participate, and the rest are all considered smaller hospitals, still just as important as any other hospital. But what I was trying to get is this: we have 18 major regional centers that aren't participating, and it sounds like the answer to that is no. But yes, I think it'd be important to get their data.
Yeah, I think following up on that discussion, what's called a hospital and what would be called sort of a clinic in other places, you know, it's important to sort of specify how many patients are seen at what kind of hospitals, because in these places, you know, 88 hospitals in Greater Accra, that's quite a lot of hospitals, and I would venture that many of them are quite small. And
looking at
and
looking at the data, I've seen hospital bed sizes ranging from 25 up to almost 900. So there's a big difference between the hospitals that are in this.
Yes, and bed sizes does not necessarily mean that's how many patients they accommodate. Truly, it would be possibly more important to know what how many patients are seen on an annual basis and for what kinds of problems.
Yeah, I think even in a table like this, to just compare the hospitals that didn't respond to the ones that did respond in terms of hospital characteristics, and all of the above, right? It's bed size, it's what their patient volume, whatever, I think there are probably a number of different things that should be looked at. And again, that might be a useful slide to show with the Ministry of Health too, right? Because that may be a gap that they want to look at. I mean, who's to say that they can't reach out to those hospitals and say, what are you guys doing? And we'd like a better sense of your care.
Yeah, well, some of them may be specialized hospitals. There are hospitals that are orthopedic hospitals. They're not going to be seeing these kinds of patients, or they may be ophthalmology or whatever. They're still called hospitals.
Right, totally.
And this number of 346, I failed to mention specialty hospitals were particularly not included. So there's 346 excluding orthopedic hospitals and like specific hospitals who would not ever be seeing breast cancer patients.
Yeah.
So can you hear me? Can you hear me?
Yes.
I was wondering, what is the percentage of those hospitals that you're talking about, the 346 that are state-owned versus private?
I need to look at the exact numbers. It's a fair amount are actually state-owned. I was looking at pathology specific on that other slide for another presentation I had this morning. Specifically state-owned.
Would you say it's a third is private or half of it is private, or?
Of those who have pathology, which I've specifically looked at that, it is so it would be, it's actually a third are government owned, a third are private. It's actually probably it's probably a little bit more than a third are government owned, a little bit more than a third are private, and then a little bit less than that are faith-based.
Okay. And I'm curious because you gave this statistic that show a huge discrepancy of the time to diagnose between what's going on in Ghana and what's going on in the US, which is stunning. If somebody has, let's say, insurance, like a good insurance plan, or they have financial means, do they have access to resources to actually speed up that process, or is still slow process?
So that's not specifically included in this part of the data, but in looking at the literature, so Ghana does have a national healthcare plan, but less than 40% of the population are enrolled in it. And in their healthcare plan, they state that all breast cancer services are covered. But once again, majority of the population aren't enrolled in the plan. It's apparently a free plan that I think you have to enroll with a couple of dollars first. And then once you're enrolled, everything else should be covered. But it's covered in the same way that this is more in discussions with other, and that the hospitals themselves don't get reimbursed very often. And so that lack of reimbursement, they put it back on the patients. The patients are having to pay for stuff. And so it's kind of a whole downstream effect.
Okay.
All right. Any other questions?
Looks like there's one in the chat, Matt.
Oh, sorry, I missed that.
Are there sufficient resources to sustain these medical devices for breast cancer diagnostics within the hospitals, or is that an issue? So basically, looking at, in some ways, the third delay, thinking of the three delays model of accessing care, of once you get to the hospital, can you access good quality care, and what are the supply chain constraints that may exist for these hospitals? Obviously, your project is not looking at that question specifically, but it seems like that would be a natural additional analysis to undertake.
Yeah, that's a very important question. I think that's partly why the asking hospitals if services are available, obviously everybody could say yes or no, but I think it was important that they added in that extra factor of, well, how available? Is this mostly available greater than 80%, or are there times where it's not available? And I was really trying to get at, yeah, we've got an MRI machine, but in reality it breaks down and doesn't work for half the year. And so it would have been nice to have this be a little bit more granular for the hospitals, because less than 80 could be 79%, it could be 1%. It's a big spectrum there. What's causing those individual delays at each hospital, we don't have that specific data, but I agree that's something very important to be evaluated.
And so where are you in this project now, and what are your next steps?
So currently, I have a draft of a manuscript written up. I have it actually, my mentor here at the School of Public Health, Dr. Ann Rosich, is currently looking over that. We also head to Ghana a week from Saturday, one to present some of this data to Dr. Atwoto, who's the head of research and finance in the Ministry of Health there. He's been really excited about this data, and he's actually been talking about potentially with Dr. Sutherland developing a real-time interface, kind of like the COVID dashboard, but really the availability of hospital-based services. And that's kind of what Dr. Sutherland's trying to work on and figure out ways to get that off the ground, because it'd be great if we could actually have this annually updated and everybody knows where it is. And then the other aspect of this is I'm starting to work on the pathology side of the manuscript as well, and write up that data.
And we have an abstract for presentation to West African surgeons as well for.
Yeah. Yeah, I think, Ray, this is the kind of work that if between Edward Sutherland and Florence Steady, if they have a team and Wisdom at the Ministry of Health, if they have a team that they can create, this is the kind of great preliminary data that could lead to substantial grant funding. And there's a lot of interest from the NCI Center for Global Health on exactly these kinds of projects and work. And it would be a great also validation of our model of having a site director in another part of the world that is supported in part by the center as a way of developing that capacity and growth. If we were to help them spearhead getting that kind of funding and growing in that kind of space, because that would be the sort of ultimate, transfer of capacity and transfer of leadership and expertise. So just something to consider, but it would require a team there to start thinking along those lines. So something to consider for your next trip.
Yeah, it seems like a great idea. And I met James Alaro, the head of the portion of global health from the NCI. He came and was on a panel a couple of weeks here at the School of Public Health, and they got a great group there.
Yeah, I think we need to this work is even far beyond a lot of the work that was presented at the Lancet launch at the Commission on Cancer in Sub-Saharan Africa launch in DC last year, with all of these big name US places, and everyone's barely scratching the surface, but we need to have a little bit more organization internally to be able to access, to really take this to the next level. These are great places to start. And
One thing I failed to mention too is Dr. Ngwa, the one who headed that commission, he's here at Hopkins, and I met with him to present some of this, and he invited me to come give a quick shot presentation at their Global Health Catalyst Summit in Pennsylvania, beginning of May. Hopefully get some other eyes on it as well.
I think that's great. I think it's just that it will be a lost opportunity for the University of Utah if more other institutions start getting involved and we're not spearheading it. So.
No, I think so I'm really excited with where things are right now. We have Sarah's work on the treatment, and then we have this one on the early diagnosis and component. And I think in trying to get that together, and with what Edward's trying to do now with really kind of getting a team together, I think is a really important aspect of, like you say, that the next step in trying to use this data, I think is really a key thing for this next while. So.
Yeah, I mean, honestly, it makes me think that setting up something like an R01 with the purpose of having a center for breast cancer research in Ghana, would be a great vision, and saying that, the subsequent steps within that would be X, Y, and Z. And I think those are some real valuable opportunities that could come up.
Great.
So.
I think what Edward and all of us probably needed some of your expertise there, and looking at those kind of opportunities as R01s, and how to work towards that. So I think that would be fantastic in this next little while. See if we can't help identify some of that area, because I think Edward would be totally thrilled to take off on something like that.
Yeah.
Here's a question: how do R01s work for non-US citizens?
Oh, the NIH is super excited about supporting, especially cancer, but almost any kind of research led by foreign institutions.
Perfect.
Yeah, there's a ton of interest and there's a ton of money. It's just a matter of people putting things together. So, and it may make sense to have it be a multi-institutional. Maybe it's a Hopkins, Utah, Ensign, and whatever, a couple of CATH or other institutions in Ghana, all working together to put it together. But I think ideally that's the sort of level that this work should probably go to, and could probably go to. But it would take some work from especially the folks in Ghana, and certainly folks here, and whoever else wants to be involved.
Yeah.
So. Yeah, great. Well, thanks for sharing the work. Congratulations on the immense quality and quantity of what's been done. And Mo, I don't know how to say your last name. Is it Sabai? I don't know how to say it correctly. For those of you who don't know, is one of our neuroscientists who is in physical therapy and has been involved in neuro rehab and has set up a neuro rehab facility in Morocco. I'd be remiss if I didn't channel Mo to say one of the other factors that need to be considered is not just access to care and treatment, but recovery from cancer care, which cancer rehab is an enormous component of the care that Huntsman provides, and even assessing what those services look like in Ghana would be another important step, and would be a great opportunity to do additional work. And there's a lot of work happening I can't give any details because I'm reviewing a couple of different grants that is looking at doing mobile health related technology and rehab in low and middle income countries. So there's funding for that too. So there's a variety of different options that would open that would be worth considering through this particular project. Thoughts, Mo, on the rehab aspect of it?
Well, I'm sure you can imagine, even in Morocco, where neuro rehab is starting to grow quite considerably compared to 10, 15 years ago. I was exposed to what's going on in the cancer field, and I can tell you what you just said apply 100%. We see some of them coming to our clinic, but I would say it's probably less than 10% of what's going on out there. When it's actually affecting the neurological functions of the patients, that's where we have a better chance to see them. Otherwise, vast majority just go home. Take care of yourself.
Yeah, absolutely. And then of course, reconstruction services, all those things are other additional to consider too. So it would be great to kind of tie in some of the work that Dr. Rockwell has done from plastics in Ghana, looking at reconstructive services and creating the training programs for reconstructive services as a great tie-in to this work as well. Because again, offering quality reconstruction services is maybe a great way to improve willingness to access care. In some ways, maybe the first delay is saying that you can actually survive, you can actually have good functional outcome, and that is a good reason to access care. But that's again additional work that our institution could really take leadership in. So, all right, well, great. The hour's almost up. So thanks for a really engaging discussion and a really great topic and so many great ideas. I don't know who we have speaking next week. I don't know actually if we have anybody speaking next week. And hopefully Anna will come back from her well-earned time off this week to give us a sense of what is on the docket for next Monday. Otherwise, thanks everybody for making time. Any last minute comments, questions, thoughts?
Yeah, just these matter brain, the tiny questions. I know how to compare Africa to European and developed country. What is your sense of where Ghana sits as when you compare it to other equatorial countries? Do they fare much better? Are they on the top 10% or top 30%?
Ghana's ahead of most of their surrounding counterparts in West Africa. They're behind South Africa and some of these other regions, but they are ahead as far as it goes for 5-year survival. Most of the other countries are
compared to neighboring Togo or Ivory Coast or Nigeria or
the exact countries I can't remember, but I do remember Ghana being high 30s versus most of the other countries being low 30s to high 20s.
Okay.
Yeah.
Cool.
Also, Suda, just separately, just a quick update, like Cambodia, just so you know some things that have been submitted. May I have just Angel tell you real quick where we are with some submission things.
Yes, so we submitted the manuscript for the breast projects in Mongolia, the tumor board. We submitted to the Journal of Surgical Research, and we also submitted an abstract about the project in Cambodia for the American.
Fantastic. Congratulations.
Yes.
Great. Well, we'll wrap up for today, and we'll reconvene on Monday, and if anyone has, and please feel free to kind of share this the link for this meeting if you feel like others would be interested in joining as well. All right, great, and I think that's about it for today.
Thank you.
Have a great day, everyone. Okay, all right, bye-bye.